Originally was going to introduce Dr. McKinney, but he has a computer catastrophe that just occurred, unfortunately. So, Zeke, I don't have your Vita in front of me right now, so I'm going to do my best. Dr. Zeke McKinney is a physician from Health Partners and the University of Minnesota. He is the Occupational Medicine Residency Director, and he is board certified in occupational medicine, preventive medicine, and lifestyle medicine. We have asked him to join us today and last evening so that he could present some thought-provoking information for us on specifically occupational health disparities as part of our inaugural efforts to try to be more sensitive to these issues in our own ERC, and perhaps as also a way to build some other relationships with Minnesota and some of our other sister and brother ERCs out there. So without further ado, Dr. Zeke McKinney, thank you so much for joining us today.
Well, first of all, thank you all for having me. If you see me look to this direction, it's only because that's where I have everybody's faces in the chat. So I just am going to be peeking over there every now and again. As Dr. Heaton mentioned, I do have another presentation at 2 o'clock. So at 2, I'm going to jump off quite promptly. But, you know, I gave this talk in about a half hour when Dr. Heaton saw it originally. And so that's my plan, to really try to get through it fairly quickly so we can have about half the time open for questions and discussion at your leisure. I'd also like to thank one of our resident physicians, Dr. Ashley Nadeau, for attending as well. But in any case, thank you all for coming. And again, feel free to ask questions on the chat. You can stop me as I go, but you know, it might be easier if we just do it at the end and we can always go back to points. So make some notes as you go. So we're going to talk about occupational health disparities. So we're going to talk about, you know, what do we know about differential occupational health risks, kind of some of the history of trust and mistrust in the OH space, the issue of the current infodemic, especially with COVID-19, but this has been a problem before. What are some of the data gaps, and then kind of how do we go about addressing these issues? So just starting with this study from Stanberry and Rosenman from 2014, looking at all the workers in Michigan, that's 4.2 million people from 2011, just to show you, like, okay, well, you can see, you know, the Black population is really in some of these, quote, lower positions, you know, clerical trades positions. White people often are in more professional positions, whereas your Hispanic population similarly are going to be in more of the trades or clerical. And the Asian population, again, actually looks like somewhat more high order jobs as well. So, but I mean, it's mixed, but, you know, there is disparities in terms of who has what kinds of jobs. That's all I'm trying to show here. Similarly, from the same study, you can look at all the occupations people are employed in. And again, looking at, you know, the percentages of the different races and Hispanic ethnicity split across here. Again, you see the Black population a lot in nursing aides, laborers, you know, driving these heavy tractor trailers. Similarly for the Hispanic population, you know, truck drivers, food servers. But again, you know, you see that there's going to be a difference in sort of these blue collar versus white collar occupations across race. And that, of course, then will portend different types of inequities or disparities in terms of exposure and hazards. You know, just looking at what outcomes look like, and this is from the same study as well, they looked at silicosis, fatal injuries, injuries by pesticides, burns, and asthma, that is occupational asthma. And again, you can see for the Black population, silicosis had a 5.5 times higher rate ratio. For work-related burns, it was 1.25. For pesticides, 4.1 for Hispanics. For fatal injuries, 1.5 times higher for Hispanics. So, I mean, again, we see over and over again, and this is just one cross-section of this, that different races and ethnicities end up having different outcomes as far as occupational hazards. And that's kind of scary when you think about it. The study from Sears in 2015, they looked at 90,000 workers over a 6-year period from 5 different states: Arizona, California, Florida, New Jersey, and New York. And again, they just did rate ratios of like all occupational injuries, falls, machinery hazards, motor vehicle traffic injuries, and assault and homicide. And as you can see in different states, but there's some consistency, you know, for the Hispanic population, there's higher rates of injury just across the board. For falls, similarly in the Hispanic population, though interestingly, that's a lower rate risk for Blacks. I'm not clear why. For machinery hazards, really high for the Hispanic population, and in some states higher for the Black population. Motor vehicle accidents, again, in some populations higher for Blacks and Hispanics, But then assaults and homicides are notably quite high for the Black population. Again, this all portends you probably all asking the questions like, wait a second, what jobs were they in? What were they doing? Who are these people? Yeah, that's one of the issues of data that we need to try to figure out. But these things at least open the door to asking those questions. So Steege and them in 2014 looked at US private sector workers. This is about 1.7 million people, 220 non-fatal injuries and illnesses, and ultimately 27,000 deaths. And again, showing males in general have higher risks of occupational hazards than females, maybe no surprise there. But when you look at race and ethnicity, again, higher for Hispanics and Blacks and American Indians. And so ultimately, again, we're seeing that our sort of disenfranchised populations are populations in these lower socioeconomic statuses more generally, and having more blue collar jobs end up doing worse. Turns out having less than a high school degree portends having a higher risk of injury. Similarly, being from outside of the continental United States also portends a greater risk of injury. And I'm sure you guys are thinking about what type of education we're providing to people and in what language. And by the way, as I've said, low wage tends to be worse. So again, no surprise. So overall, what we're seeing is, trends in precarious work in, again, people of lower socioeconomic status or of, the minority races and ethnicities, that seasonal jobs, not having, actual full-time jobs, instead of being contractors, being undocumented, having to put together jobs from multiple places and ultimately not having benefits from that, whether it's workers' compensation or just general medical insurance. Overall, there can be lack of access to care. Some people don't even have health care, but maybe will be covered by workers' compensation. But then when work comp denies their claim, what do they do then? Some people just can't afford their copays even when they do have insurance. And then again, going to this issue of training, in certain jobs, we know training isn't offered. We know PPE isn't offered. Training on PPE is not offered. People don't know how to use it. There's a lot of language or cultural barriers about, the safety and the work culture. And ultimately, these issues exist for everybody. It's just worse for these underrepresented groups. Am I going too fast, Karen? You're muted I saw you shaking your head no, so I'll take that as a good sign.
No, you're doing just fine. Thank you so much.
No problem. Thank you, ma'am. So looking at COVID broadly, again, these are chloropleth maps of COVID incidence on the left and mortality on the right, where A is white, B is Black, C is Latino or Latina, D is Asian, E is Native or Indigenous, and F is Native Hawaiian. And as you can see, again, higher incidence in the Black population, higher deaths in the Black and Latina population. That's scary stuff. But the reason I bring up COVID is because there's obviously a overlap with occupational health risks. So I love this quote, so I'm just going to read it because I thought it was really powerful. As with all diseases for which workplace environment is a root cause, the most marginalized workers with the least power and resources, that is people of color, people who are undocumented, incarcerated, women, lesbian, gay, bisexual, transgender, queer, are the least likely to have access to testing for infectious diseases and most likely to be missed in cohort enumeration. But to be honest, this isn't specific to COVID. We know this is true for all occupational diseases. COVID just has been like a perfect case study of that. So why is race such a big deal? Well, structural racism is defined, and maybe this is basic, but we all need to know the totality of ways in which societies foster racial discrimination through mutually reinforcing systems. This is really important, of housing, education, employment, earnings, benefit, credit, media, healthcare, and criminal justice. All those things sound familiar. Why? Because those are social determinants of health. But the point I want to focus on is mutually reinforcing. These things stack on each other. It's not like they're all in a vacuum. Oh, you're poor and you don't have access to healthcare. Well, both of those things make the other one worse. We know that systemic racism impacts health via social determinants of health. The 5 categories of social determinants of health as laid out by Healthy People is economic stability, the neighborhood and built environment, health and healthcare, social and community context, and education. And all of those things, again, are mutually reinforcing. I just show this web of causation on the right with maternal and infant mortality in the middle, because that's still actually a disparate issue here in the US, believe it or not. But again, drawing parallels all the way back to slavery, Jim Crow, redlining, and how these affect housing, people's food stability, how people are incarcerated. All of these things go together, and there's a lot of downstream effects. It turns out racism is its own social determinant of health, because we know these organized systems cause these inequalities And I would argue that racism is broadly part of the social and community context part of social determinants of health. Turns out colorism is actually its own social determinant of health, independent of racism. And those are also mutually reinforcing. I just like this picture because, at the middle, you see environmental lung disease as an outcome. And again, seeing all this mutual reinforcement of far external risks at a societal or global level, things at the community level, and things at the individual level, and then just intrinsic differences in people that we, can't really measure necessarily at the level of genetics yet, but we will one day. And all of these things are impacted based on your race and ethnicity and your socioeconomic status and your documented status or whatever. All these identity dimensions, and that's what we have to really look out for. So mistrust ends up being a function of his peripheral trauma. Historically, we've seen things in the research domain like the Tuskegee syphilis study or Marion Sims. And if you don't know who that is, he's considered the father of modern OBGYN, but basically experimented on slaves to develop surgical techniques. We've seen infectious disease stigmatization with AIDS, certainly in the 80s and even 90s, maybe even to this very day. And with COVID-19, people calling it the China virus. And I think a lot of that played into a lot of Asian American aggression that we saw earlier in the last year or two. In clinical settings, we know people of color are less believed about their symptoms. They are considered malingering or drug seeking or whatever seeking. We talk about difficult patients, which I don't think is a word we should use, but we do. We know socially there's issues like law enforcement violence, which is a function of racism. We know about redlining. That's what this little white block here is, just showing there are places in this country, including in my own city of Minneapolis, where this was written into the clauses of the property that, people who weren't white could not live there. And that was usually in more affluent neighborhoods. We see cultural appropriation all the time. That's why I show the Redskins logo there, which thank God is finally changing. And we know there's, certainly stigma about immigration and documented status. I mean, so there's just a million different ways, and these are only small cross sections of it, but all these things build a layer of, fear and mistrust in people. Like they can't trust institutions to care for them because they don't know how they're going to be penalized for it. In occupational health, we see this in a lot of ways. One aspect is, looking from the employer side, where, we know employers will deny that risks exist. Oh, I'm doing everything right. So, why are there people still having injuries? People are worried about me as an occupational medicine doctor. Oh, you're the company doctor. You're not worried about me. We know that people aren't always getting the best training and use of PPE. I mentioned that before. We know that people think folks want to game the system and be on work comp, which is kind of BS for the most part. I mean, I'd say that's very, very rare, only because dealing with the work comp system is such a headache, and ultimately the benefits you get out of it are not greater than the benefit of just going back to your normal life, which is all that mostly people want anyway. We know some people are, listed as contractors rather than being full employees. Uber had that problem, for example. We know there's increased likelihood of discrimination, harassment, and bullying, certainly for communities of color, or for example, for gay, queer, transgender communities. We know internally people have issues with language or culture. People may not want to speak up and say they don't speak English well enough, and maybe don't understand what's going on in the safety training. People are scared that if they report a safety issue or an injury, they're going to get blamed, they're going to get fired. And by the way, that's not really even just a fear, because that actually happens. There's this concept of John Henryism, where people will behave a certain way so they don't fall into a stereotype, like, oh, well, we know Black people are lazy, so that's why they're not doing this really hard stuff. And so inversely, you'll have people then go do the hardest jobs and get worse exposures and get more injuries because of it, despite whatever the hazards are. So that's a scary and real thing. We know that systemic racism impacts mental health in a number of ways, not only just the stigma of it generally, which is worse in communities of color, but also through how you interact with others, how you interact with doctors, how you interact with your workplace. And so again, yet another layering, mutually reinforcing factor impacting your health and safety in the workplace and outside of the workplace too. We know that mental health in the workplace can be affected by discrimination, and we know that that's a real thing. So people who actually experience discrimination in the workplace have worse mental health in general. They experience more distress on the job. They have more anxiety and depression. They have more negative emotions. They have more emotional trauma. I can summarize this more simply for you. And I'll just tell you, look, in my practical experience, and I don't exactly have data on this, but I feel pretty confident it's true. The number one and two, or both one, predictors of whether somebody does poorly after a work-related injury is, do they hate their job and do they hate their boss? And does that specifically speak to discrimination? Maybe, but my point is discrimination is surely going to make that problem worse or even more amplified that I'm describing. We see disparities in work-related disability. So this was an interesting paper, and they looked at like what you would do for compensation for spirometry, which by the way already has a race correction built in, and there's arguments to be made that that's not appropriate. And what they're showing here is the solid line is kind of like where the present state of things are, where the dotted lines are like, well, if we got rid of the race correction for lung function, you know, it'd be moved over here. Or on for hearing, they actually are saying the literature suggests strongly that Black people actually have better hearing than white people. So there should be a race correction for white people, because it ends up with more white people having compensation for hearing. And by the way, more white people having compensation for lung function. And so, you know, the arguments to be made that we're having corrections in the wrong place, either added or need to be subtracted, and ultimately resulting in differential degrees of assignments of disability, which we see this in clinical medicine too, with like kidney function and transplants, for example. We see that we know the mistrust exists in occupational health settings. I liked this study that showed concordance between people reporting injuries and the job reporting injuries. And so if you look at this graph on the right, the really dark part down here is where the person didn't report, but the job reported it. And then all the way at the top is where they both reported it. And then in between is one did and one didn't. And ultimately, you can see these gaps are bigger in the Hispanic population or in generally the non-white population. And so that's kind of scary to me, but we know that's to be true. And this goes back to that fear that people have of reporting injuries. So where do our employees get information from? Well, at the job, they get it through safety trainings. They get it from their boss. They get it from their colleagues. In the communities, you know, maybe they talk to their friends and their family. They get it from the union. They get it from different news sources or media sources. But ultimately, we know for a fact people are limited by what's considered cognitive conservatism. That's that echo chamber effect. Ultimately, people want to resist change, and so implicitly look for sources that support what they already believe, which is a problem. So, you know, that's what we need to combat and let people know that, look, you have to be open to seeing things in reality, not just because this is how you've heard it always is. And things change too. In specific groups, we know that this can be more prevalent, where, you know, just this mistrust leads to people rejecting true information. So for example, we know that Black and brown communities already mistrust institutions generally. And when I say institutions, I mean healthcare, banks, education, workplaces. You pick your favorite. We have a problem with it. I'm going to include myself, even as a privileged, educated, well-to-do person. I'd still have a nice low level of anxiety walking around in America. But as a function of that, when your boss tells you something, or when the government tells you something, or when your doctor tells you something, you're already going to be like, is that really true? And that's a type 2 error, you know, a false negative. Like, do I believe that I believe this thing is not true, even though in fact it may be true? Your mistrust also may lead you to accepting information that's incorrect because of the same mistrust. And so you may see trusted sources saying one thing, or sorry, I guess legitimate sources, but then you trust some other source that isn't an institution, but maybe it's, you know, your local naturopath or whoever, and whatever the accuracy is, and then you suffer a type 1 error. You believe something to be true that isn't. There's this attraction of conspiracy theories in what I would call, quote, conspiracy theories in groups who are, you know, underrepresented, because you experience this chronic social devaluation. Nobody understands my experience. Nobody cares about my experience. And some people would argue, you know, looking at these sort of alternative ways of thinking is a way to manage that devaluation. I'm looking for an explanation to explain why Black and brown people are dying all the time more than everybody else. But unfortunately, us calling it conspiracy theories only perpetuates that devaluation. So we have to be cautious about how we listen to this stuff and how we approach people about it, because you don't want people to ever think that you're not taking their perspective seriously. That's a big problem. We know there's an issue of information overload. Right now, the WHO has deemed it, the WHO, as in not the band, but the World Health Organization has deemed it an infodemic. There's just too much information abound. That means good information, bad information, whatever. Now they've called this infodemic because it's during this disease outbreak, but I'm saying this is a thing that existed before COVID-19. We have increasing information sources over the past several decades. We have increasing access to these echo chambers, and ultimately there's going to be more difficulty assessing accurate sources. I probably should have put a nice slide talking about, the signal to noise ratio has basically gone way down because there's way more noise and we don't know what to do with it. And that's where we, as occupational health professionals, have to do our best to get that information in the hands of the people. So I just thought this was funny, somebody had typed in COVID-19 and look at the fun stuff that came up, but this is what we're up against. Now, to some degree, we know that these results are tailored around what people are already seeking, but I thought that was kind of funny. And also proves the point of what I'm getting at. This is from Ireland's Health and Safety Authority, just some myths that they put out there. But even though this is from Ireland, and by the way, that's actually where Dr. Nato, our resident, went to medical school, even though she's from here in Minnesota. But these are myths that they show as common there. Oh, look, these health safety inspectors are just looking to catch people out and issue fines. Yeah, you ever heard about that for OSHA too? I feel like I have. Oh, well, I don't want to do all this health and safety stuff because this is going to cost me a bunch of money and not really do anything. Yep, I've heard that before. Oh, well, health and safety is just more administrative red tape. It's slowing me down from actually getting stuff done. Manual handling? You mean I just need to be told how to lift a box? This is stupid. I know how to lift boxes. Yeah. We know. Or, they say, oh, well, so many things get banned in health and safety. It's just the nanny state gone mad. Now, we don't say the nanny state here, but we say, that's the government being restrictive or, whatever the phraseology we prefer around here is. But see, it's the same worldwide. What we find is these myths actually reinforce these inequities. And so, like, for example, people will say, oh, well, we're shooting for organizational efficiency, and that's a bigger deal than individual needs. Yeah, maybe. Or, oh, well, this is a meritocracy, so, everyone has an ability to, move up the ladder. But the problem is, we know that interplays with the social determinants of health and, the status that people have and their race and their ethnicity and what they look like and how they dress and all that. Some people say, oh, well, our business is moving towards globalization. And even though that maybe comes with some bad things, it's ultimately going to be good, regardless of how much it, affects different people because of laws and policies and exchanges. And the point is, businesses are working in their own best interest. And so to some degree, they themselves are the victims of these myths, thinking that what they're doing for the net benefit of all ultimately isn't going to harm the people who are working for them or who they're serving. And that's unfortunately not necessarily true. So what's the problem with data? And by the way, Karen did a great introduction, but she forgot to mention I'm boarded in clinical informatics. And not that I'm trying to brag, but just to say that I have some expertise about data that, so you don't think I'm just going, not staying in my lane here. So, the problem in occupational health is we have all these different data sources. I show them on the right there. You have employer collected health information, clinical or research data. You have personal health, data like, your Fitbit, for example. You have population level data that you maybe can get from the health department. And you have then insurance data from the health plan. And all those data sources have lots of benefits and limitations that are not necessarily the same between them. So, you see, you have your different payers in occupational health, both in personal insurance, work comp, or the employer-based care. And those kind of are actually three separate data sources in a way. You have your legal limitations of sharing data, whether it's ADA, HIPAA, GINA, workers' compensation. You have clinical data that's segregated or should be. If you're dealing with occupational health, that should be separate from somebody's personal medical record, but it isn't always. And there's lots of arguments about which directions people should be able to see it or not be able to see it. But suffice it to say, we know in clinical data in general, people will go to different health systems. And similarly, each of those health systems are paid by different payers. So only some people have different slices of the data, and it's hard to get it all at once. Now, more broadly, we know clinical data is limited because it's rich. You have, all these lab tests and MRIs and whatever. But again, that's also usually limited to, let's say, your UAB health system, but you're not going to get it from, your other health system in town. I don't know what's in Birmingham there. Claims data, on the other hand, is broad. It'll span across health systems because, one payer is getting it all. But again, you may not have all that detailed clinical information that will contextualize it. So that's the balance we have to pick as terms of our data sources. Now, we know there are gaps in demographic data. As far as race and ethnicity, at least historically, it's gotten better now. Our EHR will actually let you pick multiple ones. But back in the day, a couple years ago, you can only pick one: white, black, Asian, native, other, multiple. Ethnicity was Hispanic or non-Hispanic. But I'm going to say, well, wait a second. If race is a social construct, what about nationality? Okay, so country of origin, cool. Well, is that cool? Because that's not a clear question to people. Some people here, like let's say in Minnesota, we have the biggest population of Somali people outside of Mogadishu. Somebody comes here and becomes a citizen. They say, I'm American. And you say, well, are you though? And what we're really getting at is country of birth. Where was somebody born? Because even though somebody may have lived here for a long time or even a little bit of time, and maybe they consider themselves American, that's great. Country of birth actually does portend outcomes as well. And that's not always clear in EHRs. And then gender, oh my goodness, don't even get me started. We know biological sex is relevant, but people's identified gender may be relevant too, especially because of discrimination, harassment, and bullying. So I'll show you proof that there's gaps, and we've known this for a while. This study on the left was in the VA medical centers in 2009. They looked at 204 cases, but the point was they were trying to show the concordance between race and ethnicity that people reported themselves as well as what was in the EHR. And for white people, it was only like 85.5%. Black was as high as 93.4, indigenous 20. Okay, it's not great, but maybe it's not that bad. This one on the right, which was in 13 primary care clinics in 2015, they did a little bit better, but still sensitivity was lower. Specificity was quite high. Okay, well, fine. Well, what does that mean? So we know that sensitivity is maximized when your false negatives are low. So what this is telling you is there were some false negatives in this case. And what that means is there was times when the electronic health record did not tell you that somebody was something, even though they themselves thought so. We actually reproduced this data in our clinics with about 800 cases, and we showed similarly that sensitivity is quite low. So again, high specificity will tell you that you are minimizing your false positives. So I would take that to mean if the EHR says somebody is Black, they probably are Black. But if it doesn't say they're Black, that might not be true. So, we have to be cautious about these data. And I think there's ways that we can get doing that better. What we did was actually give out a detailed demographic form where people could self-identify lots of things, including even more details than what's on here. And that paper is coming out later this year, I think. So we also know in occupational health, it's hard to necessarily know whether it's a work-related case. In our practice, we've tried to use the ICD-10 code Y99.0 to represent work-related injury. But you have to ask yourself, how else could you identify work-related cases? The point I am making, though, is most of the time we're not storing discrete data identifying that. You could maybe look by work comp insurer if your electronic health record does a good job at like capturing that data. Sometimes we know industry and occupation is definitely not very well coded in health records, and a lot of people have energy going into trying to fix that. Like NIOSH is working on that. But so in our practice, we keep the employer's name in text in our note. We have the job title in text in our note. But how well those really map to coded industry and occupation? And the answer is not very well. We know injury details are not always coded very well. I mean, ICD-10 is super limited, and I'll show a slide on that. But ultimately, you don't get a lot of choices for like mechanism of injury, even though usually for pathology, it's okay. Like as far as like what type part of the body was hurt and how. OICS is a system that does a little bit better at that, but nobody uses it yet. And that's really for BLS, but I think it does a good job of breaking this down. So here's examples of ICD-10. Everybody jokes about this good old one, V97.33, sucked into a jet engine. Was it really necessary? We needed that in our coding lexicon, plus minus. But you got stuff like falls on snow and ice. Okay, that's reasonable. Caught or crushed or pinched in between objects. Okay, now you're talking our speed and OC health. Contact with agricultural machinery, and they even have one that's specifically contact with a PTO. Wow, like okay, they got detailed. But the problem is, it's not detailed like this for everything, and it's kind of hit or miss. And so if you're lucky enough, it's in a domain you care about, great. But if not, and then of course, there's the same issues of sensitivity and specificity. If a clinician never sat there and coded that it was an agricultural machinery injury, you're never going to know that, even whether it was or it wasn't. So OICS is nice because, like I said, this is a BLS, Bureau of Labor Statistics developed system to try to standardize this. And they use what are called code trees, which is like a hierarchical coding system, basically talking about the nature of the injury and the part of the body, what the source was, and then what the exposure was. And so I'll show you an example of this. And I love this. And I would strongly encourage you to use it because it'll actually make your paper stand out. And I'll show you why. So basically, if you look at these four categories, again, this is just at the highest level, but it gets more and more detailed like most of these hierarchical ontologies. You have, your nature of your injury, like kind of what part of the body or how did it happen? And then you specifically have the part of the body. You have your source. Was it chemical? Was it machinery? And then kind of what the exposure was. Oh, was it a harmful substance? Was it transportation, violence, etc.? So I like this. I think it does a good job. I'm planning on using it more as time goes on. Here's why I say you should publish it, because there's only 9 papers in PubMed that actually refer to OICS. So suddenly you're going to be found when people are looking for this. And honestly, between when I presented this Karen in May and now, there actually was one more new paper. So maybe it's picking up, but here's a practical example. This is actually a paper published by one of our resident physicians a few years ago. And he took data from our clinical practice and showed that Hispanic workers have a 3 times higher rate of low back injuries and a 1.85 times higher rate of upper extremities injuries. But, and this is what led to our other study looking at race and ethnicity demographics, what does Hispanic mean? Does it mean you're from Mexico, from Spain, from South America, from Dominican? Does it mean you're white or you're black? Does it mean you're documented or undocumented? Does it mean you speak Spanish? I don't know. And even more worse, we didn't even know what job these people were in because of the coding issues I described. So we identified a problem, but we didn't really know where to go after that. And that led to our further research. And hopefully more grants coming out of that to look at this further. But ultimately, all I'm saying is the point is we have to remove the barriers. So everybody loves this picture. You know, on the left is the reality of the situation. There's a fence, there's a barrier for everybody that exists to some degree, but some people have more or less resources to try to overcome that barrier. The world of equality is, okay, give everybody the same thing, and then we should be fine, right? Well, no, people who are still set behind maybe still can't even see over the fence. Equity, which everybody talks about nowadays, is more outcomes based. Let's get everybody to the same place so they can look over that barrier. But I'm arguing for the last part, which is liberation. Just remove the barrier altogether, and we don't need to be anything special about resources, because at the end of the day, then we don't need to do anything about it. Fix the system, not, this is exactly it. Don't try to target your intervention on the person, target it on the system. That's a better way to say it. So how do we start to solve these issues? Well, look, again, we got to first start identifying these populations. And I told you the reasons why that's problematic, but we need better data. We got to address these issues of information overload. We have to listen to people's concerns and hear these myths and deal with them. And we need to make sure that people have access to all this information that we want them to have all the time, everywhere. It has to be really easy. But then lastly, and most importantly, we have to build trust and show them that we know these inequities exist and we're ready to hear what your problems are. And by the way, we have PPE for you, which by the way, that's been a real problem for healthcare clinicians during COVID. Oh my goodness. And then of course, engaging employees at all levels in safety, leadership, and ownership. So even if you're not part of the safety team, well, maybe you need to make sure once a quarter or once every so often, you get people from each of your little organizational units or teams to be involved. So then you have a voice represented there. So how do we fill these gaps? Again, employee reported demographics. If we aren't asking, we aren't going to know. And that talks about the stuff I got to about, self-identification being probably the most powerful. As I mentioned, NIOSH has current efforts kind of going underway right now to do employee reported occupational health data that's more easily coded. So then they'll sort of guide people to the right NAICS and SOC selection without them even knowing that's what they're doing. As far as injury coding, that's harder. So we have issues of, should we do manual or assisted or automated? Automated is more like machine learning, but we're not there yet. Decision support is a little bit assisted. We can kind of walk our way there through questions. I don't think there's a great system for that, but it could be. There's a paper on this from 2015 looking at auto coding injury narratives, and it's plus minus. So basically, I would say this is the part. Injury coding is where we still have the most work to do, but everything else we have some solutions and can implement them probably sooner than later. So again, don't make any assumptions about what people know or don't know, because people come into your workplace with different degrees of training expertise. People have different lived experiences. Ultimately, saying this guy's black and that guy's black, they must have the same problems or same concerns is not true. Everyone's an individual, whatever they look like, wherever they come from, regardless of gender, whatever. Don't assume two people are the same. You have to listen to people's concerns. That's true for me as a doctor in clinic. That's true for me as an occupational health professional at the worksite, whatever it is. But, notice there will be divergences between what the employer is saying, oh yeah, no, everything's safe, we got everything in place. And the employee is saying, no, I'm concerned if I use this machine, my hand's gonna get cut off. Like, that's a real thing. And, make sure you talk to the unions who are representing the employees or other employee groups so that they have a voice in safety, as I mentioned. Make it accessible. Is there a centralized resource? Do people know where that is? Are there competing interests? Like, oh, yes, the safety team says, hey, you guys got to follow these rules. But then they walk away and the supervisor says, like, yeah, that's cool and all, but look, we got to meet quota today. So just get moving, guys. And it doesn't matter if your back hurts. And ultimately, is safety truly a part of the culture that employees realize is part of their means to success? Are you giving benefits or bonuses for people being more safe? And you can do that. So we got to rebuild employee trust. And a lot of this involves, justice, equity, diversity, inclusion, things that everybody's been talking about, and make sure that we have adequate representation of historically minority communities in workplaces at leadership levels, at the lowest levels, at all levels. we got to stop these issues of retributive justice, where we just punish people over everything, because ultimately workplace transgressions disrupt trust. And there are better ways to go about doing this. I tend to be a fan of restorative justice, where, look, if there's a minor thing that somebody does, you can talk to them about it and make them understand why it's a problem for you and maybe why they did it. And, you don't have to punish somebody over it. Save the punishment for when people are doing major things. Oh, you've embezzled $1 million from my company? Yeah, we can't really let that pass. Sorry, dude. And that's okay. Nobody's going to fault you there. But at the end of the day, we have to engage employees at their level. Don't make them use some inane online system that's hard for them to use or a pain in the butt, or do it on their off hours. Don't make people all do it in English if you have a large Spanish speaking population. Ultimately, be clear about why this is of interest to you. If it is just an administrative thing, then say that. If it is a reason you're like, well, honestly, we had a guy die here last year and we don't want that to happen again. Well, that's maybe more compelling. What is all that about? Oh, well, it turns out our insurance rates go up when people get hurt. And that means we can't pay you as much or give you bonuses at the end of the year. Oh, now you got my attention, for example. So at the end of the day, again, inclusion starts with trust. It's been proven in all kinds of literature, medical, social science, you pick it, that a diversity of experiences, a diversity of knowledge improves outcomes, no matter how you slice it, whether it's academic or occupational or engineering or whatever. And so that has to start with management, because that's who has the power to do this stuff. And you have to respect people, and you have to really give people pride in what they're doing. Be inclusive to what people's concerns, interests, and values are. So that's the last slide. Let's talk. I went a little more than halfway. Pretty good. No questions in the chat, so probably filled your minds too much.
So Zeke, I have a question. I'll start.
Yes, ma'am.
This is all great information, but I'll echo our student from last night.
Uh-oh.
Where do we start in our actual practices?
I'm going to go back to one of the things I hit on multiple times, which is listening. Just ask the employees, what are their concerns? There's like this paper I cite all the time in medicine, an occupational medicine paper that says, like, what is the most dangerous part of your job? That's what doctors need to be asking people. And, so do safety professionals, because you'd be surprised. The people on the ground know that a lot better than their safety leadership, usually.
I was actually going to also mention, this is Ashley, Dr. Nato from the residency program in Minneapolis. We see a lot of patients who have come from urgent cares or emergency medicine. And like you were saying, the coding is not there. They were injured at work. And a lot of the times it's just not listed in, their family medicine doctors about the injuries. So we're just not getting good documentation to even know where the problem, we're at the tip of the, iceberg. We don't know the actual problem, amounts. And then I do think that's something that is really important that we need to push for is really good documentation for the injuries.
Totally agree. I don't have anything to add. Thank you, Dr. I got rid of the slide just so we could see each other's faces. So if you guys want me to refer back to something, I can pull it back up again.
I have a question.
Well, I just wanted to go to Claudia first, who raised her hand.
Oh, sure. Oh, sorry. Yeah, go ahead.
Sorry. My name is Claudia Donna Martinez. I'm a second-year master's student here at UAB, pursuing my MPH in Healthcare Organization and Policy. That being said, I do really appreciate you bringing up Spanish-speaking populations and Hispanic populations, as I work directly with diabetes Spanish-speaking populations at my job. And there is definitely a disconnect between their health disparities and language barriers. So I just want to say thank you for touching on that in your presentation.
Thank you. Okay, back to Victoria.
Yes. Hi. I was intrigued by your comments about the data where you had said that if the people were, say, Black and they would mark themselves as Black in the documentation, that was mostly accurate, but if they weren't, then then they might have one of these other classifications. I'm curious I have a lot of friends who have mixed racial families now. So yeah, so is there future options to be able to click more than one, or how do they choose? Do they choose the mom? Do they choose the dad? Or do they, I'm just curious about the data point of view of how what we're trying to analyze and figure out may be skewed by these families that are coming from multiple, areas. So anyway.
Yeah,
that was
well,
my
as a
question.
mixed race individual, I've had to deal with this my whole life. So the issue of electronic health records only allowing you to pick one, I think is going to the wayside. Like our electronic health record has changed in that regard in the past few years. So that the single selection thing is not as much of an issue, thankfully. But the self-report issue is still a problem because think about it. How often are your patients entering data in your EHR? And the answer, I imagine, is 0% of the time. So that's why these studies looking at what would self-report versus what's going to the EHR make a difference. Now, why do I bring this up? Well, it's possible, and I don't know if this is true, that somebody who looks white in skin tone walks up to the desk and checks in, and without asking them, the person checking them in says, okay, they're white, or they're black, or they're whatever. And similarly, somebody walks up and talks to them in English. They say, oh, this guy speaks English, so that's his preferred language. Even though that person might say, no, actually, I want to do this visit in Spanish. I mean, but sometimes we don't even ask these questions. And so I'm not sure that people are doing that, but I would guess so. But all I'm saying is there's at least a layer of translation because we know that patients aren't putting that data in themselves. And so there may be mistakes made at any number of levels. I don't know if that totally answers your question, but the point is,
Yeah, the second part of that was how do you think it might be skewing the data and the whether it's mitigating the actual effects or making the effects more? Does that make sense? Like,
yeah,
which
I think
way do you think it might be sway?
I think there's both differential and non-differential bias, and here's why. So black, what the hell does that mean? I mean, some people you might think would consider themselves black don't. Some people who I mean, the opposite problem would exist, but the difference is, let's say for somebody who's black, descendants of slaves in the United States, that's me, versus somebody who's black, my parents just moved here from Somalia. We actually have different cultural milieus and different, occupational, educational, health risks overall. That would be true for different white populations, true for different Asian populations. But when we group all these things together, then you're sort of washing out that effect. And, you see that when we do, like, let's say disease epidemiology with different types of cancer, all brain cancer, even though, glioblastoma is different from medulloblastoma or whatever, I'm just making up stuff now. But you get my point that, that grouping together washes out the effect a lot. So we see that. But in some ways, you may see it more pronounced depending on which way this is getting skewed. Like, for example, there are a lot of Hispanic or Latina populations that look white on the surface. And so people would say, oh, that's white, even though they themselves say, I'm not white. Or inversely, somebody who looks very dark skinned, like in South America, those people don't necessarily consider themselves black. They just, it's just not what they would call themselves. And so, it really varies a lot how we use this terminology, and categorizing it to these high levels, I think gets more washout than probably not, but it may end up skewing the effect in one direction or the other.
Hey, Zeke.
So,
How are you today?
very well, thank you. How are you?
I'm doing well. So you mentioned benefits or bonuses for people being more safe, right? Did I hear you say that?
Yeah, and we've seen that happen in reality, I think.
Yeah. So the reason it kind of stuck out to me when you said that, once upon a time in my previous life, I was a health and safety manager for BP Oil, east of the Rockies convenience retailing sector. And so I kind of witnessed this personally, where we did have built into our bonus structure, you would get a bonus if you didn't have any recordables or non-recordables. And it became quite problematic when I would go around to all my sites. And what I would see is that we would get feedback from the employees, because a lot of these sites, the fuel operation sites, were in minority communities, some are not. But I would see a lot when I would do my site visits that the employees, it would feed in the managers would create a culture because they wanted to get that bonus, right? So they create a culture. Well, if it's a near miss, let's not really talk about it. Let's, sweep that under the rug. I want to get my bonus this quarter, right? And it would kind of feed into that whole concept of, okay, they don't care about us. They don't care about us. And so, we ended up ending the program. and we stopped it. And so I'm wondering, you mentioned it, but I'm wondering if it's something that is still something that could be problematic and not really shouldn't be done, even though it sounds like a good thing, right? So
yeah, I mean, it's a balance, and this is what I was talking about with competing interests. I'm not saying that's necessarily the best thing, but maybe it's as simple as, hey, if you attend all your safety trainings for the year, we'll give you, $100 Target gift card or whatever. And so then there's really arguably no competing interest with reporting an injury, I don't think. But then, quotas, for example, as I mentioned, are a competing interest, because then people may be working more unsafely to try to meet that goal. But you've mentioned it appropriately yourself too, like, oh, well, if you have less injuries, then you'll get more money. And it's like, okay, well, then we're just not going to tell you we have injuries. That's a real thing. We know that happens. So it's really a fine balance. And that's a little bit of an informatics problem, which is looking at the unintended consequences. I just want to look at stuff in the chat here. So Claudia says, I am Latino and I often experience being labeled as white, even though I do not identify that way. Ta-da! I guess I was right. Katie Parrish says, David, that also trickles down to my side. I'm an occupational health nurse practitioner. I feel immense pressure for my clients to keep their injuries non-recordable, even when a patient needs more care than the standard first aid. And I'll tell you that I've seen that pressure too. And it really doesn't faze me, because I just got to do what's right for the patient regardless. Now, with that being said, I mean, there is a borderline, like, okay, maybe I think this guy will benefit from more than 200 milligrams of ibuprofen. I don't have to give him a prescription. He can take that over the counter. I mean, you could do some of that stuff, a little bit of wiggle. And also, by the way, like, sending people for evaluation does not change the first aid thing. You can get somebody an x-ray, you can get them to see even a couple pretty simple things before you trigger that. So I would say be careful about knowing where that line is. Elizabeth Thomas, you did have her hand raised, and I apologize because I was sitting there gabbing off with everybody else. Can you go ahead, ma'am?
No problem. I just didn't think you might not be able to see my hand. So I'm the deputy director for the Occupational Health Nursing Program in our Southern California ERC at UCLA and UCI. And I'm also the program director or assistant program director for our advanced practice nursing program at UCLA. And so I really enjoyed your talk. And I was particularly interested in how to address some of those data gaps, the OIICS. I would like to learn more about that. So I'm going to look up those PubMed papers, but I'm wondering if we're going to be able to get a copy of your slides, particularly the reference list.
Yeah, I made a couple modifications from when Karen previously saw it. So I just need to send her and Policia the newest version, and then they can send it out to all attendees. I have no problem with that.
That would be great. I would like to make one comment about the input that people are able to have to their health records. At UCLA, if you belong to any of the UCLA plans, every time you have a visit, you do a pre-check-in, and you are actually asked to confirm all your demographics, and you can change that. So they ask you, what's your race, ethnicity, preferred language, all of those things. Every single time you have a visit, you can look at that and confirm it or modify it. And of course, that answers that question. I mean, that's obviously the preferred way to do that. So I'm really glad that everybody has that opportunity in our health system.
Yeah, and I think more and more health systems are doing that. I mean, my clinic specifically just recently started doing a sort of pre-visit electronic check-in as well. And I think that you have that option also now. It's just that, leading up to this point in time, a lot of places have not been doing that. And so I think some of these problems are going to self-correct, but there are still going to be gaps. But I appreciate you bringing that up. That's actually a really good point.
And one other thing, I'm the owner of what's a Song Brown grant, which is a training grant for family nurse practitioners. And the one we're doing this year is on bias and how that impacts healthy food resource access for our clients. And so we're going to start with looking at actually research bias, because the research course is the first course our students have, and then moving to implicit bias and identifying the students and the faculty identifying their own implicit biases, and then starting to look at how they can, as they go into their clinical experiences, identify what healthy food resources are available and how racism and systemic racism impacts that, because there's a direct link, of course, and there's good research to back that up. And then as they get near the end of their program, actually plan a project that will help impact that. And one of their courses, which is a policy and role course, they have to look at policies that impact that as well. So it's threaded through the whole 2 years of their nurse practitioner program. And all of our occupational health students, of course, will have that content, as well as all of our nurse practitioner students.
Well, I look forward to you presenting that at this venue. If Karen and Paulie should bring you back in a year, or whenever you guys get some good results out of there.
Yeah, well, it'll be 2 years before we see the fruition of the full thing. So, yeah.
Dr. Nato in the comments said, something I'm seeing now too is the gender category listing more options of male and female, and that will be interesting how data is used and incorporated going forward. That's true, and thank goodness they're doing that, because again, we'll start to be able to parse out some of those differences. So here's the thing, if we get more granular data, then we can start looking at these little pockets of populations. Oh, here's the Somali population working as healthcare assistants in Minneapolis. Great. Well, right now we can't really do that. Because even if you have that granular data, it's easy to roll it up if you want to say, okay, let's just look at everybody who is, quote, Black. But, you know, there's, again, it's a plus minus, but at least then you can do it bidirectionally, or to whatever degree of resolution you want.
I had a question. Zeke,
Tanya,
this
hi.
is Tanya Carter. Hello, everybody. So you talked about it a little bit last night about the corrections made for GFR. Also in your papers about the lung function and the hearing protection. So I just want to know, I mean, because I don't know, are they still in practice about correcting downward for Blacks with the lung injuries versus the whites, and also with the hearing? Is that something that still goes on today? And I mean, to me, that sounds like a structural racism issue. So, I mean, I'm just curious about that. Is that something that's still ongoing?
The bad news is that stuff is totally ongoing to this day without much change, with one exception. So this is what they consider race-based medicine. And because race is not a biological construct, we're realizing like we need to mostly get rid of that stuff. And there may be occasions where it's appropriate, but these ones I'm showing you definitely aren't. Right now, people are looking at kidney function, estimated glomerular filtration rate. There was like last year, maybe 10 hospitals in the whole country that had gotten rid of it. I think here in the Twin Cities over the past year, like most systems have initiated that process. I don't think it's gone yet. You'll have to look in your own local area. So I think we'll see in the next few years that like that phases out without anybody really even hearing about it. The lung function is still there. The problem, so what Tanya's talking about, I talked about this last night, is kidney function is when it's reported in clinical medicine, you get an estimation and then an estimation if you're Black. And it's up to the clinician to decide which one they want to use or whatever. But the Black one looks better. And the problem is, of course, that leads to downstream disparities when it takes longer to get to, you know, kidney transplant or something. But we see that in other things like the spirometry one I mentioned, and I was just looking at spirometry today, and that still exists. The problem was the NHANES data, where they based it on, had very little or very small numbers of non-white populations. And so they're, again, drawing these correction inferences based on very small sample sizes, which we know from an epidemiologic perspective is problematic. But anyway, you know, look, that stuff's only being identified in medicine. Like, I mean, it's been identified for a while, but people are only giving enough of a hoot to do something about it now. So the bad news is it's still there and still a problem. Karen, this doesn't need to be the last question. We got 7 minutes. I'm cutting it right to like 1:59.
Okay, all right. Well, I wanted to let you have a chance for a
I don't need to
break
read.
and a glass of water, but okay, that's fine.
I'm cooking.
Okay.
I'm on your dime here.
All right. Well, then Dr. McKinney's willing for one more question.
Yeah, but if it comes to like 1:59 and a half, I'm just going to like leave Zoom. I might even be in the middle of talking. No, I'm just kidding.
I have a question for you that has nothing to do, well, it does have to do with occupational health. It's a little bit off topic, but the issue of the frontline workers and COVID and so forth. I see all of your musical instruments behind you and know that you have an interest in music, but it made me think, so much of what's been talked about in mental health issues and occupational and frontline workers is specifically related to the critical care providers, the ED providers, and so forth. But it seems that the occupational medicine providers and the occupational health nursing providers certainly have had some difficulties too, and some moral distress in occupational health nursing, at least in the beginning of the pandemic when there were shortages of supplies and they weren't able to really do what they were supposed to do. Are you seeing that in your area? And what suggestions do you have for occupational health nurses and other providers who are trying to figure out how to keep themselves healthy right now?
Ooh, that's a big question. So yes, I would say I've seen that same thing. I mean, at least for me personally, I mean, we've had more work in occupational medicine, not just from the clinical perspective, but like actually, you know, doing more consulting for employers and schools and whatever who need information about how do we return to work, how do we interpret this guidance, you know, that kind of stuff for sure. With police and firefighters, especially at the beginning, we're like, how do we, you know, actually help people safely? You know, me personally, I've been doing a lot more, you know, COVID work in the community and equity work, and I'm not feeling burnt out in terms of like I like the work that I'm doing, but it's a lot. It's overwhelming. And I think that's part of it too. To some degree, I mean, we need to take breaks. I mean, you're going to have to do that for yourself because the system is not going to do it for you. There was a barrier here in Minnesota with our medical licensing board asking people on their licensure whether or not they have a diagnosis of like a mental health condition. And that's been a barrier for people getting mental health treatment. It just changed now to ask if they haven't like not treated mental health condition or, you know, whatever. And so that's been a big improvement. And Tanya says, can we healthcare begin saying health as opposed to mental health? Mental health phraseology we stigmatizing. Yeah, I usually try to say behavioral health or maybe even emotional health. But I agree that is something that needs to change. Anyway, more to Karen's point. I think for now, I think a lot of us have to do it for ourselves, but we have to advocate as people who, you know, deal with workplace health and safety, that we have to take care of our workers. And we know healthcare clinicians, doctors, nurses have some of the worst rates of burnout or moral injury, more appropriately, than any other groups in occupations in the country. I mean, almost like the highest. Deborah Adams asks, can you have slides or link a recording? Yes, I'm going to give slides to everybody. They can give them out. I think I answered that before. They have a recording. That's up to them whether they're going to give that out. I cannot comment.
We will.
But I'd like a copy of the recording too.
For a mere $5 and a coupon off the box of saltine crackers, you can have it. Just kidding. Well, seriously, folks, I think we should probably wrap it up now. It's 1:57. I don't want Dr. McKinney to have to just go crazy rushing. Thank you all so much. This has been another great presentation and discussion session. And we're very excited that Paulicia is going to be kind of heading up our DEI initiative for the ERC. And
wait. Victoria said she doesn't know what moral injury is. Oh, I got to say this.
Yes. Okay.
So no, this is really critical. I'm sorry to interrupt you, Karen, but I want to take my last minute to say this. So burnout is a very stigmatizing term too, because it's like victim blaming. You know what I mean? Oh, well, you got assaulted. Why did you walk down that dark alley wearing that dress? You know, no, we can't do that. Doctors and nurses aren't bad because we're trying to do our job. It's a systemic problem. And moral injury is the fact that you feel your ethics and morals are being compromised because you cannot provide care to patients in the way that you feel you should because the system does not have the resources to allow you to do so. That is real. And no one should say burnout. All right, sorry, Karen, that's it.
No, that's wonderful. Thank you very much.
Thank you.
Thank you so much, Zeke. And folks, we're so happy that you all joined us this afternoon, and most likely be on the lookout. We'll have Dr. McKinney back for another session, perhaps maybe not later in this year, but in 2022. Hopefully we can work that out related to informatics and leveraging data to help us identify these disparities